1, 2,
And review 70-year-old female
Oh shit, I almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep your heart again.
Pulse check. No pulse.
No more pulse.
Yeah.
Here, what do the ECMO people say?
And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh. Oh.
You know, usually when we talk about a medical diagnosis, there is this underlying expectation of precision.
Right, like it's engineering or something.
Exactly. Like you break your arm, you go to the ER, the x-ray shows that jagged white line right across the radius, and the doctor just points at the screen and says, well, there it is. Broken.
Yeah, it's binary. I mean, it's completely objective. There's really no debate about what you're looking at.
Broken or not broken. It's clean. And, you know, it's comforting in a way. We like things to be visible. We like our pathophysiology to be neatly categorized, boxed up, and labeled.
But then you step into the world of obstetric nursing.
Oh boy, do you ever.
Right, and specifically you step into the way a pregnancy interacts with the human body's endocrine system, and suddenly that metaphorical x-ray machine is just, well, it's completely broken. We're looking at a diagnostic landscape that is honestly incredibly murky.
It really is.
Yeah.
Because, I mean, how do you spot the abnormal when the normal baseline is absolute chaos? What's normal, third trimester pregnancy fatigue, versus, say, a dangerous creeping thyroid crash? Or what's normal, expected morning sickness, versus life-threatening dehydration that could literally put a mother into cardiac arrest?
It's the absolute definition of diagnostic muddy waters, and that is exactly why this specific physiological intersection is so heavily tested on nursing board exams, specifically the NCLEX.
They love this stuff.
They really do. The exam raters know that the line between a healthy pregnancy and a metabolic disaster is razor thin.
Well, welcome everyone to this deep dive. Now, we have a very specific mission today. For you listening right now, we know exactly why you're here. You are an aspiring nurse.
Yep, staring down the barrel of those exams.
Exactly. You're facing your OB nursing exams, your rigorous clinical rotations, and ultimately you are preparing to conquer the NCLEX. So today we are officially acting as your elite OB nursing educators.
We are your personal exam coaches and your clinical mentors.
That's right.
And as your mentors, we know exactly what you're going through. I mean, you're completely inundated with information.
So much information.
You've got these massive 1,000-page textbooks. You have endless PowerPoint slide decks. You've got hundreds of normal and abnormal lab values just staring back at you, blurring together. It is beyond overwhelming.
So we're going to change the strategy. Instead of drowning you in a dry textbook reading or, you know, just walking down a syllabus like a table of contents, we are going to sift through your specific source materials on complications of pregnancy, specifically endocrine disorders.
And we are going to aggressively apply the Pareto principle.
The 80-20 rule.
Exactly. As an exam coach, I can tell you that trying to memorize every single sentence in your textbook is a recipe for severe burnout.
It's impossible.
Right. We are going to extract the 20% of high-yield facts, the recognizable clinical patterns, and those critical safety concepts that are going to give you 80% of the value on your exams. We're pulling forward the most testable, most repeated, and most safety-critical content.
Okay, let's unpack this, because before we even get into the specific conditions, I want to talk about the baseline. Setting the stage for all these disorders requires us to get over the first major hurdle for nursing students, which is understanding how pregnancy inherently alters the maternal metabolism in the first place.
I want to speak directly to you, the future nurse listening to this right now. Put down your highlighter for a second.
Let's listen.
Yeah, just listen. To think like a safe, competent future nurse, you have to move beyond just rotely memorizing random lab values. The NCLEX doesn't just want to know if you can memorize a number. It wants to know if you understand what that number means for your patient sitting on the exam table.
And to understand that, we have to look pregnancy for what it really is. I mean, it isn't just a growing belly. Biologically speaking, pregnancy is essentially a 9-month stress test on the mother's organs.
That is the perfect way to frame it. It's a state of accelerated starvation and massive hormonal upheaval. The entire physiological system is hijacked and redesigned to funnel nutrients, oxygen, and resources to a growing fetus.
And the endocrine system is driving all of it.
Right. The glands producing the hormones, that's the chemical engine driving the entire process. And when that engine misfires, or when the maternal body just can't keep up with the stress test, we see the severe complications we're about to discuss.
So let's start with the heaviest hitter in your materials. This is undoubtedly one of the most tested topics in all of maternal newborn nursing. You'll absolutely see this on your exams. We're talking about diabetes in pregnancy.
Yes. And when we talk about diabetes in pregnancy, we have to establish the high-yield core right out of the gate. You have to differentiate between the types because the pathophysiology dictates your nursing care.
Right, so let's start with pregestational type 1 diabetes mellitus.
So this is an autoimmune disorder. The mother's pancreas has been under attack by her own immune system, leading to the complete destruction of the beta cells.
And just to clarify for everyone, the beta cells are the specific cells in the pancreas that manufacture and secrete insulin. So in type 1, insulin production is completely absent.
Right. That patient comes into the pregnancy already requiring external injectable insulin just to survive.
And then we have pregestational type 2 diabetes.
Which is entirely different at a cellular level. It's driven by insulin resistance, heavily influenced by genetics, diet, and lifestyle factors. The mother's pancreas is still making insulin, sometimes even more than normal, but her body's cells are basically ignoring the signal.
Like the locks on the cellular doors are jammed.
Exactly. The locks are jammed, so the insulin cannot open them to let the glucose inside.
And then we have the third category, which is entirely unique to the obstetric population, gestational diabetes mellitus, or GDM. This develops during pregnancy, usually showing up in the second or third trimester.
And your sources note that this affects 5 to 9% of all pregnancies.
Think about that practically. If you were working on a labor and delivery floor with 20 beds, statistically, 1 or 2 of those patients has GDM at any given time. That is a massive chunk of your future patient population.
It's huge. And to understand GDM, we have to ask the fundamental question, why does pregnancy cause diabetes in a previously healthy woman? To answer that, you have to understand the hormonal shifts of the second and third trimesters.
Right.
The placenta is not just a sac. It's an incredibly active, powerful endocrine organ, and it produces a specific hormone called human placental lactogen, or HPL.
Ah, HPL, the biological villain of our story. I saw HPL all over the source text. But let's dig into the why. What exactly is HPL doing at a cellular level?
Well, from the mother's perspective, it might seem like a villain, but from the baby's perspective, HPL is the ultimate hero. The entire evolutionary purpose of HPL, along with a surge in other pregnancy hormones like maternal cortisol and progesterone, is to intentionally create a state of increased insulin resistance in the mother.
Okay, wait. Stop right there. Why on earth would the mother's body intentionally make her resistant to her own insulin? That sounds like biological self-sabotage.
I know, it sounds like it, right? Until you look at the mechanics of fetal feeding. Insulin's job is to push glucose out of the bloodstream and into the mother's cells for energy.
Right.
But if the mother's cells become resistant to that insulin, they can't absorb the glucose. So more and more glucose just stays floating around in the maternal bloodstream.
And where does all that maternal blood eventually flow? Straight to the placenta.
Exactly. By making the mother slightly insulin resistant, HPL ensures there is a continuous, incredibly rich supply of glucose readily available to cross the placental barrier and feed the rapidly growing fetus.
That is wild. It's a brilliant evolutionary survival mechanism. The baby is basically ensuring its own food supply.
Yeah.
The baby is essentially hijacking the mom's food delivery truck by blocking her own cells from unloading the cargo.
That is a phenomenal analogy, yes. The baby locks the mother's loading dock, so the truck has to keep driving straight to the placenta.
Wow.
Now, in a completely healthy, normal pregnancy, the mother's pancreas recognizes this resistance. It senses that the blood sugar is staying high, so it compensates.
How does it do that?
We see a biological process called beta cell hypertrophy. The insulin-producing cells in the mother's pancreas literally grow larger and work overtime to pump out massive amounts of insulin to overcome the HPL resistance.
So her body just turns up the volume on insulin production to match the resistance.
Precisely. But here's where the pathology kicks in. In some clients, this compensatory mechanism fails. They experience beta cell dysfunction.
The pancreas just gets overwhelmed.
Exactly. It simply cannot produce enough insulin to match the massive, overwhelming resistance caused by the rising HPL. The maternal blood sugar spikes and stays high. And that exact moment of failure is when gestational diabetes develops.
Let's connect that back to the timeline, because this is a massive aha moment for test taking. If HPL is the primary driver of this resistance, and the placenta doesn't get large enough to pump out massive amounts of HPL until the later stages of pregnancy, well, that completely explains why gestational diabetes usually isn't diagnosed in the first trimester.
Exactly.
The placenta just isn't big enough yet to cause the problem.
You've absolutely nailed it. That is clinical reasoning right there. If you understand the mechanism of HPL, you naturally understand the timeline of GDM. You do not even have to memorize it. It just makes logical sense.
Okay, so let's talk about the clinical presentation. Who is most likely to experience this pancreatic failure? Nursing exams love risk factor questions, and we need to know who to watch closely.
Definitely.
The sources list several key risk factors you absolutely must have in your mental toolkit. A maternal BMI greater than 25 or greater than 30 for specific demographic populations. And polycystic ovary syndrome, or PCOS.
Let's pause on PCOS because I want you to understand the why. Why does a syndrome involving ovarian cysts lead to diabetes in pregnancy?
Right. What's the connection?
It's because PCOS is fundamentally an endocrine and metabolic disorder characterized by profound baseline insulin resistance. Women with PCOS are already starting the pregnancy with insulin resistance.
Oh, I see.
Yeah, so when you add HPL on top of that, their pancreas fails much faster.
That's a great connection to make. Other risk factors include a prior history of GDM in a previous pregnancy, a strong family history of type 2 diabetes, or a previous A1C sitting in that pre-diabetic range of 5.7 to 6.4%.
And here is a highly tested one. A previous large for gestational age infant, or LGA. The cutoff they give in the literature is an infant weighing over 4.08 kilograms, which translates to about 9 pounds.
Okay, so if a patient tells you, oh yeah, my last baby was 10 pounds, your internal alarm bell should be ringing for gestational diabetes.
Oh, absolutely. Now, let's talk about why it matters clinically. As your exam coach, I can tell you that diabetes in pregnancy is a goldmine for NCLEX writers because it fundamentally impacts both maternal safety and fetal safety.
It hits every priority nursing area: airway, breathing, circulation, and fetal distress.
Let's look at the maternal impacts first. The sources highlight an increased risk for pre-eclampsia, which is a severe, life-threatening blood pressure crisis. And there's a risk for polyhydramnios.
Let's explain that one. Poly, meaning many or much, and hydramnios referring to the amniotic fluid. Why does diabetes cause excessive amniotic fluid?
Think about the mechanism of high blood sugar. What happens to a diabetic adult when their blood sugar is 300?
They experience polyuria. They urinate constantly because the kidneys are trying to flush out the excess glucose.
The exact same thing happens to the fetus. The fetus is swallowing amniotic fluid, processing the sugar-rich blood from the mother, experiencing fetal hyperglycemia, and therefore fetal polyuria.
Oh, wow.
Yeah, the baby is peeing excessively into the amniotic sac. That excess fetal urine is what causes the polyhydramnios.
That is wild. The excess fluid is literally the baby's sugary urine. That is a vivid, unforgettable way to understand that complication.
It sticks with you.
It really does. The sources also mention an increased risk for maternal urogenital infections. And again, the mechanism makes sense. Sugar in the urine is basically an all-you-can-eat buffet for yeast and bacteria.
Exactly. And we cannot ignore the long-term post-pregnancy implications. A client who develops GDM has a 60% recurrence risk in future pregnancies.
That's high.
And even more terrifying, they have a massive risk of developing overt, permanent type 2 diabetes mellitus within 5 to 10 years postpartum.
Yeah.
We are talking about a permanent, life-altering chronic illness stemming from this pregnancy.
I want to slow down here for a second because the psychosocial impact is explicitly pointed out in your materials, and it's something nurses deal with every single day at the bedside.
Right.
Imagine being a pregnant mother. You're already exhausted, and suddenly you're handed this diagnosis, the anxiety of potentially harming your baby, the depression, the profound feelings of guilt or shame, feeling like you caused this by eating the wrong things, even though we know it's driven by HPL.
It's so unfair.
Plus, the sheer financial and temporal strain. You suddenly have extra maternal fetal medicine appointments, endless daily finger pricks, dietary restrictions, and antenatal testing. It's an incredibly heavy burden.
It's a phenomenal point. Empathy is a core nursing competency. You are not just treating a blood glucose level, you're treating a terrified mother. Your patient education needs to be delivered with immense compassion, reassuring her that the placenta's hormones are driving this, not her occasional craving for ice cream.
So true. Okay, let's pivot to the fetal and newborn impacts, because this is where the really critical, high-stakes exam questions live. First, congenital malformations. The literature is specific here. This is primarily a risk with early pregestational diabetes, specifically type 1 or type 2, that is poorly controlled during the very first trimester.
Right. And you must understand the timeline of fetal development to know why. The first trimester is the period of organogenesis. This is when the neural tube is closing, the heart chambers are forming, and the spine is developing.
Okay.
High levels of maternal circulating glucose are teratogenic. The oxidative stress from hyperglycemia literally disrupts the cellular formation of the heart and the neural tube. If the sugar is out of control in week 6, the baby's heart might not form properly.
But with gestational diabetes, which develops later in the second or third trimester, the organs are already fully formed. So what's the danger there?
The danger shifts entirely from organ formation to fetal growth and birth trauma. Here is the absolute golden rule you must memorize. Maternal glucose crosses the placenta. Maternal insulin does not cross the placenta.
Let me repeat that because it's so crucial. Sugar crosses, insulin does not.
Exactly. So the fetus is being continuously bathed in a high-sugar environment. The fetal pancreas recognizes this massive sugar load and responds by pumping out huge amounts of its own fetal insulin to manage it.
Makes sense.
And here is the kicker. Insulin is a remarkably powerful anabolic growth hormone. It builds tissue. Yeah. So a fetus producing massive amounts of insulin is going to grow excessively large. This leads to macrosomia.
And a large macrosomic baby leads to a cascade of delivery complications. Preterm birth, birth trauma, and the absolute dread of every labor and delivery nurse shoulder dystocia.
A true nightmare.
This is when the baby's head is delivered, but the baby is so disproportionately large in the torso that the shoulders get physically wedged behind the mother's pubic bone. The baby is stuck. The umbilical cord is compressed. It is a catastrophic obstetrical emergency where you have mere minutes to dislodge the baby before permanent hypoxic brain injury occurs.
Yes. The text also mentions organomegaly, meaning the baby's internal organs, particularly the liver and heart, are physically enlarged due to that insulin growth factor. But let's talk about the absolute most critical, highest yield newborn complication you will see on your exams. The #1 priority assessment for a baby born to a diabetic mother.
Postnatal hypoglycemia.
Yes. And I want to break down the cellular mechanism here because it feels incredibly counterintuitive to students. The baby was just swimming in sugar for 9 months. They are huge. They are macrosomic. Why on earth are they born with dangerously low blood sugar?
Right. Let's paint the clinical picture. Imagine the moment of birth. For 9 months, that fetus has been receiving a massive, continuous flavy infusion of maternal glucose through the umbilical cord. To handle that fire hose of sugar, the fetal pancreas has hypertrophied. It's huge, and it's churning out massive industrial amounts of insulin.
Then the baby is delivered. The obstetrician clamps and cuts the umbilical cord. In that exact fraction of a second, the maternal glucose supply is completely and totally cut off.
But the baby's pancreas doesn't know the cord was cut.
That is exactly the mechanism. It takes hours or even days for the newborn's hypertrophied pancreas to realize the sugar supply is gone and to downregulate its insulin production. So for those first few critical hours of life, the newborn has astronomically high levels of circulating insulin with absolutely zero maternal glucose coming in to balance it out.
So all that excess insulin acts like millions of little Pac-Men, violently shoving whatever tiny amount of glucose the baby has left into the cells, stripping the bloodstream bare. Their blood sugar just absolutely plummets.
And glucose is the only fuel the brain can use. If left untreated, severe neonatal hypoglycemia will cause seizures, coma, and permanent irreversible brain damage.
So critical.
This is why, as a newborn nursery nurse, your absolute top priority for a macrosomic baby is checking that heel stick blood glucose within the first hour of life and watching for signs of hypoglycemia. Things like jitteriness, lethargy, poor feeding, a high-pitched weak cry, or apnea.
That is such a clear way to visualize it. Cut the cord, cut the sugar, but the insulin keeps pumping. Okay, let's look at expected versus concerning findings for the mother. How do we separate a normal pregnancy from a diabetic one?
Expected findings are your standard annoying pregnancy symptoms, but you also need to have the expected lab values memorized. For a pregnant client, a normal fasting blood glucose is less than 95 milligrams per deciliter. A 1-hour postprandial, meaning exactly 1 hour after finishing a meal, should be less than 140. A 2-hour postprandial should be less than 120. And the hemoglobin A1C should be less than 6%.
So what are the concerning cues? The text points out that classic diabetes symptoms might actually be entirely missed by the provider because they perfectly mimic normal pregnancy. Polyphagia, polydipsia, polyuria, being excessively hungry, thirsty, and peeing all the time. Slow wound healing, dry skin, and visual disturbances. I mean, what pregnant woman isn't hungry and peeing all the time?
Exactly. Relying on subjective symptoms is dangerous. The clinical pearl here, the thing you must look for in a clinical scenario, is objective data. A massive concerning finding is a positive discordance in fundal height.
Let's explain fundal height. This is when the nurse uses a tape measure to measure from the mother's pubic bone to the top of her uterus, the fundus. After 20 weeks, the measurement in centimeters should roughly equal the weeks of gestation.
Right. So if she's 28 weeks pregnant, she should measure about 28 centimeters. But if she's 28 weeks pregnant and measuring 34 centimeters, you have a positive discordance. She's measuring significantly larger than her gestational age dictates. You must immediately suspect macrosomia and polyhydramnios. And what causes those? Gestational diabetes.
Let's move into priority nursing actions. If you are the clinic nurse, what are you doing? Step 1 is screening. The text says we do a glucose tolerance test, or GTT, prior to 24 weeks for at-risk clients, like those with PCOS or a BMI over 30. But the standard universal screening for every single pregnant woman occurs between 24 and 28 weeks, and that is the 1-hour GTT.
And you must know the parameters of the 1-hour GTT for your exams. This is a screening tool, not a diagnostic tool. It requires absolutely no fasting. The client comes in, drinks a highly concentrated 50-gram sugary glucola drink, and their blood is drawn exactly 1 hour later.
And the magic number here is a 140. If the result is greater than 140 milligrams per deciliter, the nurse must flag it. That's the threshold. Greater than 140 triggers the next step, which is preparing the client for the definitive diagnostic 3-hour screening.
I love the analogy you used earlier. The 1-hour test is just the bouncer at the club. It just flags people who look suspicious. The 3-hour GTT is the actual interrogator. How does the 3-hour test work?
For the 3-hour GPP, the rules change entirely. The client absolutely must fast overnight. They come into the clinic in the morning and get a baseline fasting blood draw. Then they drink an even heavier 100-gram glucose load. Then they have to sit in the waiting room, and their blood is drawn at exactly 1 hour, 2 hours, and 3 hours post-ingestion.
And to confirm a clinical diagnosis of gestational diabetes, 2 or more of those 4 values must be out of range.
Let me list those ranges for our listeners to visualize and memorize. Fasting greater than 95, 1 hour greater than 180, 2 hour greater than 155, 3 hour greater than 140. If 2 of those hit, they have official GDM. So once the doctor makes that diagnosis, what is the nursing treatment cascade?
Treatment step 1 is always non-pharmacological first, assuming the numbers aren't wildly out of control. We start with nutritional counseling and moderate exercise. The dietary breakdown the text provides is very specific and highly testable. 30 to 35 kilocalories per kilogram of body weight, spread evenly throughout the day in 3 meals and 2 to 3 snacks to prevent spikes and crashes.
The macronutrient split is also specific. 40% carbohydrates, 20% protein, and 40% fat. Plus, a massive focus on complex, high-fiber carbohydrates, because fiber physically slows down the digestion and absorption of glucose in the gut, preventing those sharp blood sugar spikes.
But if diet and exercise aren't enough to keep the fasting glucose under 95, we move to treatment step 2, which is pharmacological intervention. And this is where we have to look closely at the different types of diabetes.
Right.
For type 2, they either continue their pre-pregnancy regimen, switch to an oral medication like glyburide or metformin, or start insulin. The target blood glucose is exceptionally tight, between 3.0 and 7.0 millimoles per liter, or 55 to 126 milligrams per deciliter.
And here's where we hit one of the absolute biggest, most devious exam traps regarding type 1 diabetes. I want everyone listening to pause and focus on this because it shows up on the NCLEX all the time.
Oh, yeah. A client with pregestational type 1 diabetes will actually need a decreased dose insulin during the first trimester, and then they will need a massively increased dose in the second and third trimesters.
Okay, I have to stop and play the role of the confused nursing student here because that feels like a trick question. Why on earth would a type 1 diabetic need less insulin in the first trimester? They are pregnant, they're growing a human being, their metabolic rate is increasing. Shouldn't they need more of everything?
It absolutely feels like a trick, which is exactly why it is a classic NCLEX trap. The test writers want to see if you understand the physiology or if you are just guessing. Think about what actually happens in the first trimester of pregnancy. Number one, the rapidly developing fetus is vigorously utilizing maternal glucose for its initial cellular development, naturally siphoning sugar out of the mother's blood.
Okay, so the baby is acting like a little glucose vacuum.
Exactly. Number two, what is the hallmark universal symptom of the first trimester?
Nausea and vomiting. Severe morning sickness.
Right. The mother is frequently nauseous, she's eating significantly less, she has food aversions, and she's often vomiting up what little she does manage to eat, so her overall intake of carbohydrates drops off a cliff.
Oh, I see it now. If she continues injecting her normal pre-pregnancy dose of insulin while simultaneously eating way fewer carbs and having the fetus vacuum up the glucose in her blood, she's going to crash.
Precisely. She is at a massive, critical risk for severe maternal hypoglycemia. Her blood sugar will absolutely tank. So to keep her safe, the provider must decrease her exogenous insulin requirement early on.
That is brilliant clinical reasoning. It isn't just a fact to memorize, it is a mechanism. And then once she hits the second trimester, the nausea fades, she starts eating again, and more importantly, the placenta gets huge and starts pumping out massive amounts of HPL.
Yep. The insulin resistance skyrockets, and suddenly her insulin needs shoot way, way up.
You have to understand the timeline of the symptoms and the hormones to get the medication titration right. That is how you pass the NCLEX.
Absolutely.
Moving on to intrapartum, which means during labor and postpartum care. The text notes we should consider inducing labor before week 40. Often, providers will induce around 39 weeks if the client is on insulin, or even earlier if there is suspected fetal macrosomia to prevent that shoulder dystocia we talked about. During labor, they need continuous CTG cardiotocography monitoring. Why? Because the placenta of a diabetic mother degrades faster, putting the fetus at high risk for distress during the contractions and postpartum.
The absolute priority postpartum is exactly what we discussed earlier, monitoring neonatal glucose levels with heel sticks to catch that hypoglycemic crash. We also vigorously encourage early and frequent breastfeeding. Colostrum, the early breast milk, provides the baby with an immediate, easily digestible source of glucose to stabilize their blood sugar.
And for the mother, her placenta is gone, so the HPL is gone. Her insulin resistance should drop immediately.
Yes, her insulin needs plummet the moment the placenta is delivered. But you must test her fasting glucose and HbA1c at her 6-week postpartum visit to see if the GDM truly resolved or if the pancreatic damage was permanent and she is transitioning into overt type 2 diabetes.
Okay, let's lock this entire section in with some memory anchors. When you're sitting in your exam and a question about dietary rules pops up, I want you to visualize the 4-2-4 rule. 40% carbs, 20% protein, 40% fat. 4-2-4.
And for the 1-hour screening cutoff, memorize this simple phrase. 140 is the 1-hour limit to know. If that 1-hour glucola test comes back over 140, you are picking up the phone, calling the provider, and setting up the 3-hour diagnostic test.
Let's summarize the gestational diabetes section. We promised you the 80-20 rule. If you only remember 5 things from this massive topic for your exams, make it these 5. Number 1, human placental lactogen, or HPL, is the placental hormone that intentionally causes insulin resistance in the 2nd and 3rd trimesters to feed the baby.
Number 2, a 1-hour GTT, greater than 140 milligrams per deciliter, demands a 3-hour GTT follow-up. The 1 hour is the screen, the 3-hour is the diagnosis.
Number 3, type 1 diabetics require a decrease in their insulin dose during the first trimester due to nausea and fetal glucose use to prevent severe hypoglycemia.
Number 4, fetal macrosomia and devastating neonatal hypoglycemia are the highest risk complications that you must monitor for.
And number 5, your immediate postpartum priority is monitoring the newborn's heel stick glucose, and your maternal priority is reevaluating her glucose at 6 weeks postpartum.
That is high-yield, exam-passing gold right there.
Okay, we are going to smoothly transition away from the pancreas. We just talked about how HPL alters maternal metabolism. And we briefly touched on how first trimester nausea can affect blood sugar. Now, we're going to look at that early pregnancy nausea, but we're going to look at what happens when it crosses the line from annoying morning sickness into an acutely dangerous, life-threatening metabolic crisis.
Let's dive into topic number 2, hyperemesis gravidarum, or HG. Let me be very clear. Hyperemesis gravidarum is a severe pathological condition. It affects up to 3% of all pregnancies and frequently requires acute hospitalization. It is vital that you, as a clinician, do not dismiss this as just bad morning sickness. Morning sickness is physiological. HG is pathological.
Let's hit the pathophysiology. What exactly causes a woman's nausea to become so extreme that she cannot keep down a sip of water for weeks? The sources point to massive abnormal elevations in HCG human chorionic gonadotropin. This is the hormone that turns a pregnancy test positive.
Yes, HCG is a primary driver of the nausea center in the brain. And the text specifically links these massive HCG spikes to two phenomena: multiple gestations, like twins or triplets, where you simply have more placental tissue pumping out the hormone, and more dangerously, molar pregnancies.
Let's take a quick detour and explain what a molar pregnancy is, because that shows up on exams all the time as a distractor or a related concept. A hydatidiform mole, or molar pregnancy, is basically a genetic error during fertilization. Instead of growing a viable embryo, the tissue that was supposed to become the placenta grows into an abnormal, non-cancerous tumor inside the uterus.
And if you look at it on an ultrasound, it looks like a cluster of grapes. Because it's placental-type tissue growing out of control, it secretes astronomical, dangerously high levels of HCG, far higher than a normal pregnancy. So if a patient has a molar pregnancy, their nausea is going to be incredibly violent.
The sources also mention an increase in estradiol, genetic predispositions, and surprisingly, infections with Helicobacter pylori, or H. pylori. Now, I have to ask for the mechanism here. H. pylori is the bacteria famous for causing stomach ulcers. Why on earth would a stomach bug cause extreme pregnancy vomiting?
It's a fascinating physiological intersection. H. pylori alters the gastric pH and causes baseline inflammation of the stomach lining. When you take a stomach that is already inflamed and infected by H. pylori, and then you dump massive amounts of pregnancy hormones like estrogen and HCG on top of it, the stomach becomes hypersensitized.
Oh, that makes sense.
Furthermore, there's a theory of cross-reactivity where the immune response to the H. pylori infection inadvertently amplifies the hormonal nausea triggers in the brain. If a patient has severe intractable HG, testing them for an underlying H. pylori infection is a critical diagnostic step.
That is wild. The risk factors to watch for are nulliparous clients, meaning this is their first pregnancy, so their body has never been exposed to these hormone levels before, and clients with a previous history of HG in a prior pregnancy.
But let's talk about why it matters clinically and why we need to slow down and really look at the psychosocial impact here. HG leads to severe clinical dehydration and profound electrolyte imbalances, which we'll discuss. But the psychosocial trauma is staggering.
Imagine this clinical vignette. You have a 24-year-old patient who's been vomiting 15 to 20 times a day for 6 straight weeks. She cannot work. She cannot care for her other children. She literally cannot leave the bathroom floor. The smell of her partner's soap makes her violently ill. She's experiencing profound social isolation.
And on top of that, she goes to the ER, and a provider who doesn't understand HG tells her, well, if pregnancy is tough, try some ginger ale and saltines. The medical gaslighting is immense.
Horrible.
These women experience deep depression, suicidal ideation, and even legitimate post-traumatic stress disorder from the sheer trauma of relentless, uncontrollable vomiting and starvation. As a nurse, validating their suffering, telling them, I believe you, this is not normal, and we are going to fix this, is just as important as the IV fluids you're about to hang.
That is so true. Empathy is a vital sign. So as a nurse, how do we separate the expected versus concerning? Your textbooks give us expected normal lab values that you need to have memorized. Potassium should be 3.5 to 5 milli-GQL, sodium 136 to 145 milli-GDL, calcium 9 to 10.5 milli-DDL, glucose 74 to 106 milli-GDL. Those are expected in a healthy pregnancy.
The concerning priority findings are persistent nausea and vomiting, coupled with objective signs of clinical dehydration. You are assessing the patient for dry mucous membranes, look at her mouth, lips, and eyes, look for skin tenting, ask about dizziness upon standing, which indicates orthostatic hypotension from low blood volume.
You also need to assess her urine output. Dark, concentrated, or strong-smelling urine, or very infrequent urination means the kidneys are panicking. They're holding on to whatever tiny amount of fluid is left in the body to maintain blood pressure.
You'll also see a rapid heart rate tachycardia. The heart is trying to pump a significantly lower volume of dehydrated blood around the body, so it has to beat faster to maintain perfusion. And a very late, incredibly dangerous sign is confusion or lethargy. That indicates severe electrolyte derangement or cerebral dehydration.
This brings us to the priority nursing actions. And there is a very specific objective assessment tool mentioned in the text that you need to know. The PUQE score. PUQE, the Pregnancy Unique Quantification of Emesis score.
Right. To use the PQE score, the nurse assesses 3 specific things over the past 12-hour window. the duration of nausea in hours, the absolute number of actual vomiting episodes, and the number of dry heave or retching episodes.
Okay, let me provide an analogy here. In neurology, we use the Glasgow Coma Scale to assess consciousness. We don't just say, he looks pretty out of it. We assign numbers to eye-opening and motor response to get an objective score. The PUQE score is essentially the Glasgow Coma Scale for throwing up.
That is a brilliant comparison. And it's so important because, as we mentioned with the medical gaslighting, relying on a 1 to 10 pain scale for nausea is highly subjective. A patient might say her nausea is a 10, and a dismissive provider might think she's exaggerating.
But the PUQE score removes the subjectivity. It forces the clinician to quantify the danger. If you, the nurse, document that the patient has vomited 8 times in 12 hours, dry heaved 6 times, and experienced continuous nausea for 10 hours, that generates a severe PUQE score. It mandates medical intervention. It empowers the nurse to advocate with hard, objective data. Doctor, her PUQE score is severe. She is hypovolemic. We need admission orders.
Exactly. It protects the patient. So what orders are we anticipating? You need to draw labs immediately. A CBC to look for hemoconcentration because her blood is literally thicker due to fluid loss. A comprehensive metabolic panel to look at those electrolytes, specifically potassium and sodium. And an H. pylori screening.
Let's talk about potassium, because this is a massive NCLEX safety priority. When you vomit, you are losing massive amounts of gastric acid, which is rich in potassium.
Right. And hypokalemia low potassium is deadly. Potassium is the electrolyte responsible for the repolarization of the cardiac muscle cells. Without sufficient potassium, the electrical action potential of the heart becomes unstable. Severe hypokalemia from HG can cause fatal cardiac arrhythmias.
Wait, really? From throwing up?
Yes. This patient could literally go into cardiac arrest from throwing up. That is why checking the potassium level is an absolute priority.
Wow. Okay, so for treatments, we're immediately starting IV fluids, usually lactated ringers or normal saline, to correct the dehydration. In severe refractory cases where the patient cannot tolerate anything by mouth for weeks, they might need TPN, total parenteral nutrition. This is IV nutrition delivered through a central line directly into the bloodstream, bypassing the paralyzed, inflamed gut entirely.
Pharmacologically, we are giving potent antiemetics like ondansetron or promethazine, antihistamines which act on the vestibular system, and high-dose vitamin B6, which has been shown to reduce pregnancy nausea.
And do not neglect the non-pharmacological nursing care. Help the client identify and avoid sensory triggers. Use ginger supplements, which actually have robust clinical evidence for reducing mild to moderate nausea. Try acupressure wristbands. And crucially, provide that psychological support.
Now let's talk about the top exam traps for HG. I'm going to give you a mock NCLEX question scenario right now. A client at 8 weeks gestation presents to the emergency department with severe, unremitting nausea, vomiting 10 times a day, and a weight loss of 8 pounds. Which of the following provider orders should the nurse anticipate? Option A, instruct the client to eat dry saltine crackers before getting out of bed. Option B, administer a 1-hour glucose tolerance test. Option C, prepare the client for a pelvic ultrasound. Or option D, administer oral potassium supplements.
Oh, that's a tricky one. Let's break it down using the distractor answer strategy. Option A, the saltine crackers. That's the ultimate distractor. That's the treatment for normal morning sickness. This patient has lost 8 pounds and is vomiting 10 times a day. She is way past crackers. Option B, the GTT, is for diabetes at 24 weeks. Completely irrelevant here. Option D, oral potassium while she's vomiting 10 times a day. If you give her an oral pill, she's just going to throw it right back up.
Exactly. Which leaves option C, prepare the client for a pelvic ultrasound. Why? Because you must identify the underlying cause of the abnormally high HCG causing the hyperemesis. You are anticipating an ultrasound to check for twins, or more dangerously, that high date form mole we discussed. High DAG means IHCG. You have to look inside the uterus to see what is producing it.
That's fantastic logic. Let's give some memory anchors for this section. For the PUQE score criteria, remember the acronym VHD, vomiting, heaving, duration. VHHD over a 12-hour window. And as the expert just said, the ultimate hook to remember the etiology is high HCG equals high GAG. Look for the mole, look for the twins.
All right, let's solidify the 5 most important things to remember about hyperemesis gravidarum for your exams. Number 1, HG is pathological, not physiological morning sickness. It is severe, persistent nausea and vomiting, leading to clinical dehydration, starvation, and dangerous electrolyte shifts.
Number 2, elevated HCG, frequently from multiple gestations or a molar pregnancy, is a primary culprit you must investigate via ultrasound.
Number 3, you must monitor the metabolic panel and know the normal versus abnormal ranges for potassium. Remember, low potassium causes lethal cardiac arrhythmias.
Number 4, the PUQE score standardizes the assessment of HG severity by objectively measuring vomiting, heaving, and nausea duration over a 12-hour window.
And number 5, priority treatment is fluid and electrolyte replacement via IV, potent antiemetics, and in the worst cases, TPN to bypass the gut.
Excellent. We're moving methodically through these endocrine disasters, and you are building a massive foundation of clinical judgment. We're going to pivot one last time, and we're going to use a concept we just learned to build a bridge to our final topic. We just talked extensively about how HCG levels spike in early pregnancy, causing nausea. Well, it turns out, at a molecular level, ECG has another trick up its sleeve.
It does, and it's a fascinating quirk of human biology. At a molecular structural level, the HCG hormone looks very, very similar to TSH thyroid-stimulating hormone. They share a nearly identical alpha subunit.
Okay, so they look like identical twins to the body's receptors.
Exactly. So as HCG levels rise rapidly in early pregnancy to support the fetus, the mother's thyroid gland gets confused. The HCG binds to the thyroid's receptors, pretending to be TSH, and tricks the thyroid into thinking it's being ordered to work harder. This leads to an increase in T4 hormone secretion and a temporary physiological enlargement of the thyroid gland.
This physiological quirk provides the perfect organic transition to explore the metabolic engines of pregnancy. Topic number 3, thyroid disorders. Let's start with the high-yield core for hypothyroidism, an underactive thyroid.
The text says overt hypothyroidism affects about 3 to 5% of pregnancies. We already know there's a massive increased demand on the thyroid after implantation because the metabolic rate of the mother increases. But there is a second highly testable factor here, estrogen.
Estrogen is surging during pregnancy. What does it do to the thyroid?
High levels of pregnancy estrogen trigger the liver to increase the production of something called thyroid binding globulin, or TBG. Now, binding is the key word here. When thyroid hormones, T3 and T4, are bound to these proteins in the bloodstream, they're inactive, they're handcuffed. They cannot enter the body's cells to do their metabolic job.
Oh, wow. So because estrogen creates a massive army of these binding proteins, the thyroid has to work twice as hard to produce significantly more hormone just to ensure enough of it remains free and active in the blood to keep the metabolism running.
Precisely. A healthy thyroid just revs up, hypertrophies slightly, and handles the extra workload. But a marginal thyroid, or a thyroid that's under autoimmune attack, simply fails under the stress of needing to produce so much extra hormone.
The primary causes of hypothyroidism listed in your sources are Hashimoto's disease, which is an autoimmune condition where antibodies destroy the thyroid gland, congenital issues, or an iodine deficiency.
Let's explain the iodine piece because it helps you remember the pathology. Why does a lack of iodine in the diet cause the thyroid to fail? If you look at the molecular structure of thyroid hormone, it is literally built out of iodine atoms. T3 has 3 iodine atoms, T4 has 4.
Right.
If a pregnant mother does not have enough dietary iodine, her thyroid physically lacks the building blocks to manufacture the hormone, no matter how hard the brain yells at it to work.
That's a great mechanistic explanation. Now let's briefly look at hyperthyroidism, an overactive thyroid. This is much rarer in pregnancies, almost entirely driven by Graves' disease. In Graves' disease, the body produces a rogue mutant antibody called thyroid-stimulating immunoglobulin, or TSI.
And just like HCG mimics TSH, this rogue TSI antibody also mimics TSH. It locks onto the thyroid gland and permanently turns the switch to the on-end position, forcing the thyroid to churn out massive toxic amounts of T4 hormone. So on a lab report, you will see a dangerously elevated T4 level, but interestingly, you will see a nearly undetectable TSH level.
Why is the TSH near zero if the thyroid is overactive?
Because of the negative feedback loop. The brain senses that there is way too much T4 flooding the body, so the pituitary gland panics and completely shuts off its own production of TSH, desperately trying to tell the thyroid to stop. But the thyroid isn't listening to the brain, it's listening to the rogue TSI antibodies.
That is a classic NCLEX lab interpretation question right there. High T4 plus low TSH equals hyperthyroidism. But let's step back and ask why this matters so much in the context of pregnancy. Beyond the mom feeling tired or jittery, why are we so worried?
Let me be very direct here as your clinical mentor. Unmanaged thyroid issues are absolutely catastrophic for fetal development. The fetal thyroid gland does not begin functioning on its own until around 10 to 12 weeks of gestation.
So for the entire first trimester, the baby has no working thyroid of its own.
None. Before week 12, the fetus is 100% reliant on the maternal thyroid hormone crossing the placenta to survive.
And what exactly does the fetus use that maternal thyroid hormone for?
Neurological development, brain growth. The architectural wiring of the fetal central nervous system is entirely dependent on T4. Severe, untreated maternal hypothyroidism in the first trimester severely and irreversibly impacts the cognitive development of the fetus, leading to profound intellectual disabilities.
That is terrifying.
It is. It also massively increases the risk of early pregnancy loss, pre-eclampsia, placental abruption, where the placenta violently tears away from the uterine wall postpartum hemorrhage, and preterm labor.
The mother's thyroid is literally building the baby's brain. What about the risks of hyperthyroidism?
Hyperthyroidism carries its own severe risks, notably maternal heart failure. The hypermetabolic state forces the heart to beat so fast and so hard that it eventually fails. There's also the risk of thyroid storm, which is a life-threatening, acute hypermetabolic crisis involving fever, extreme tachycardia, and altered mental status.
And the baby.
For the fetus, the massive influx of maternal TSI antibodies can actually cross the placenta and cause fetal hyperthyroidism, leading to fetal tachycardia, poor growth, and fetal goiter. This is why your sources emphasize the absolute need for serial ultrasound growth indicators for hyperthyroid clients.
Okay, let's talk expected versus concerning presentations. The expected lab values provided in your source are critical to memorize for your exams. The normal reference range for TSH is 0.35 to 4.9 MIUL. The normal reference range for T4 is 0.6 to 1.8 MZDL. Now, the text mentions subclinical cases where the labs might be slightly off, but the patient feels fine. We are worried about overt cases.
Let's do another clinical vignette. A 32-year-old pregnant client at 28 weeks comes into the clinic. She complains of profound fatigue. She has severe constipation. She has gained 15 pounds in the last month. She feels cold all the time. And she has peripheral edema, swollen ankles.
Okay, stop right there. I have to push back as a student again. Fatigue, weight gain, constipation, swollen ankles. Isn't that literally just a normal Tuesday for a woman in her third trimester of pregnancy?
Yeah.
How in the world is a triage nurse supposed to look at a pregnant woman who says, I'm tired, my feet are swollen, and I can't poop, and think, yeah, she has Hashimoto's disease?
You have just identified the ultimate, most devious NCLEX trap for thyroid disorders in pregnancy. You're exactly right. The symptoms of overt hypothyroidism perfectly, seamlessly mimic a normal, albeit uncomfortable, pregnancy. This is why it is so easily missed by providers.
So how do we catch it? What's the golden ticket?
The key clinical differentiator, the objective data point you must look for in an exam question to distinguish a hypothyroid crash from a normal pregnancy, is the vital signs, specifically the heart rate.
Bradycardia.
Yes. Normal pregnancy causes a slight increase in maternal resting heart rate due to the massive increase in blood volume. The heart is pumping more fluid, so it beats a little faster. If you have a pregnant client presenting with fatigue, edema, weight gain, and a resting heart rate of 52 beats per minute, alarm bells should be ringing loudly. Bradycardia points directly to a systemic metabolic slowdown, which means you need to check those TSH and T4 lab values immediately.
That's a phenomenal distinction to make. Look at the vital signs. What about overt hyperthyroidism? How does that present?
Hyperthyroidism is the exact opposite. It's an engine redlining. The concerning signs are flushing, profuse sweating even in a cool room, severe anxiety or panic attacks, a racing heart or severe tachycardia, fine hand tremors, changing bowel habits, often frequent diarrhea because the gut motility is hyperactive, and a total inability to sleep.
All right, let's move to priority nursing actions in pharmacology. If the patient is hypothyroid, we must administer synthetic thyroid replacement hormone, primarily levothyroxine. And there is a massive patient education point here that nursing instructors absolutely love to test. The nurse must teach the client to avoid taking their prenatal vitamins within 4 hours of taking their levothyroxine.
Let's explain the why so you don't have to blindly memorize it. Why separate them? Because prenatal vitamins are packed with heavy minerals, specifically iron and calcium. If a patient swallows an iron pill and a levothyroxine pill at the same time, the iron and calcium physically and chemically bind to the levothyroxine molecule inside the stomach. It turns it into an insoluble complex that the intestines cannot absorb.
So it just passes right through their digestive tract.
Exactly. If they take them together, it's as if they didn't take their thyroid medication at all. Their T4 levels will stay dangerously low, putting the fetal brain at risk. You must aggressively educate the patient. Take the levothyroxine first thing in the morning with a glass of water on a completely empty stomach, wait an hour to eat, and do not take your prenatal vitamin until lunch or dinner.
What about pharmacological actions for hyperthyroidism? We administer antithyroid medications, but the timing is highly tested. The text gives us two specific drugs, propylthiouracil, or PTU, and methimazole. PTU is given until the 16th week of pregnancy. Methimazole is given after the 16th week.
The reason for this complex medication switch is a balancing act between teratogenicity for the baby and liver toxicity for the mother. Methimazole works better overall and has fewer side effects for the mother, but it is associated with specific severe birth defects like aplasia cutis, where the baby is born missing skin on their scalp, if given during the critical first trimester organogenesis window.
So methimazole is dangerous early on.
Right. PTU, on the other hand, does not cross the placenta as easily and is much safer for the fetus early on. However, PTU carries a very high risk of causing sudden, severe maternal liver toxicity. So we make a clinical compromise. We use PTU for the first 16 weeks when the baby is forming and is most vulnerable to defects. Once the organs are fully formed, we immediately switch the mother to methimazole for the remainder of the pregnancy to protect her liver from the PTU.
The goal is always to use the absolute lowest possible dose of either medication to maintain the maternal T4 in the high normal range, ensuring we don't accidentally push the mother into hypothyroidism and starve the fetal brain.
Let's hit the memory ankles for this section. To remember the medication timing for hyperthyroidism, use the acronym PTU, pre-16 treatment usually. PTU, pre-16 treatment usually.
And for the levothyroxine separation, remember this rhyme. 4 hours for 4. Wait 4 hours between levothyroxine, which is T4, and your prenatal vitamins.
And fundamentally, if you get confused on an exam, just remember what the metabolic engines do. Hypo equals a slow metabolism bradycardia, cold intolerance, constipation, weight gain. Hyper equals a fast metabolism, tachycardia, hand tremors, diarrhea, weight loss.
Okay, if you only remember 5 things about thyroid disorders from this deep dive, lock these in your brain. Number 1, maternal hypothyroidism severely threatens fetal neurological brain development in the first trimester because the baby relies entirely on the mom's T4.
Number 2, the physical symptoms of overt hypothyroidism seamlessly mimic normal pregnancy, but the key objective clinical differentiator is bradycardia.
Number 3, you absolutely must educate the patient to separate levothyroxine and prenatal vitamins by at least 4 hours to prevent physical absorption blocking by iron and calcium.
Number 4, for hyperthyroidism, use PTU until week 16 to protect the baby, then switch to methimazole to protect the mom's liver.
And number 5, normal TSH during pregnancy is 0.35 to 4.9 MIUL.
Excellent summary. We have covered a massive amount of highly testable ground today.
We really have. We stepped back from the dry textbook, we sifted through your sources, and we pulled out the absolute most critical high-yield facts for your exams. We talked about how the placenta acts as a rogue endocrine organ, pumping out human placental lactogen to drive insulin resistance and gestational diabetes, ultimately putting the newborn at massive risk for severe postnatal hypoglycemia once the cord is cut.
We explored how surging HCG levels, especially from molar or multiple pregnancies, drive the severe dehydration, hypokalemia, and psychosocial trauma of hyperemesis gravidarum, and how to objectively quantify that danger using the PUQE score to advocate for your patient.
And finally, we discussed how thyroid hormones act as the master metabolic engine, dictating fetal neurological development and the critical importance of medication timing and spacing to ensure that hormone gets absorbed.
You have absolutely mastered the 80-20 breakdown of endocrine disorders in pregnancy. As you head into your clinical rotations and eventually sit for your NCLEX, I want to offer a final piece of strategy as your exam coach. Nursing exams are not trying to trick you for the sake of being mean. They're trying to ensure you are safe. When you read a complex, paragraph-long question, always cut through the noise and prioritize maternal airway, circulation, and fetal distress. Ask yourself, what will kill this patient the fastest?
That's the golden rule.
Right. And always look for the abnormal finding hiding inside the expected complaints of pregnancy. Look for the bradycardia hiding behind the normal fatigue. Look for the extreme dehydration and weight loss hiding behind the morning sickness.
That is phenomenal advice. Trust your clinical judgment. Before we wrap up, looking at all these lab values and specifically the mechanisms of gestational diabetes, it got me thinking about something bigger. Something beyond just the 9 months of pregnancy.
It's a fascinating rabbit hole. We know from the text that gestational diabetes gives a mother a 60% recurrence risk and a massively elevated risk of developing permanent type 2 diabetes within a decade. But I want you to think about the fetal environment.
Right, the baby inside that high sugar environment.
Exactly. If that newborn was bathed in a high glucose, high insulin environment for 9 critical formative months of cellular development, how does that epigenetic programming alter their own metabolic baseline? How does it affect the architecture of their pancreas 30, 40, or 50 years down the line?
Wow, that's heavy.
It is. When you are a nurse managing a pregnant client's blood sugar today, teaching her the 4-2-4 diet, you aren't just nursing 2 patients. You might very well be witnessing and positively influencing the metabolic blueprint for the next generation. Your nursing interventions today literally echo into the future.
What a powerful, profound way to look at the impact of OB nursing. You are literally shaping the future of human health. To the aspiring nurse listening to this, you've got this, you have the knowledge, you understand the why behind the pathophysiology, you have the clinical reasoning, and you have this exam in the bag. Thanks for diving deep with us.